chemotherapy and ensure that patients taking regular treatment for 6 months. What is conclusion? Early diagnosis and treatment are future for the better outcome. Then multidisciplinary approach for management of the patient of view will have the help of pathology, biochemistry, radiology, and microbiology, which department is important for the diagnostic aspect and public department for the logistics. Community results in the suppose there is a INS, if you apply this disease medicine by spread INS prophylaxis and identification of the early case of tuberculosis, we can prevent these complications. Previous references, basic drug is a Facebook of Tuberculosis by research like CTS, the elaborate discussion of the patient.
Thank you so much, sir, for this excellent knowledge of this topic. I would request, as a token of deep respect, Dr. Neelam Redkar, HOD Department of Pathology, to please come up on stage and present Dr. Shivhari Ghorpade sir with a moment. Now I would like to invite on stage Dr. Neelam Redkar, Professor HOD Department of Wood Hospital, to share her insights on TB meningitis, clinical presentation, diagnosis, and challenge.
We have few lines on. Good morning. At the outset, I would like to thank the Parkar Madam and Ghorpade sir for giving me an opportunity to talk on tuberculous meningitis. What I am going to do is I am going to take case-based approach so that you understand how to be investigate and treat the cases of tuberculous meningitis. Tuberculous meningitis is considered as a neurological emergency. If it is not diagnosed in time and treated properly, it can lead to a lot of complications, and it may cause MDR tuberculosis and very serious complications. So it is a neurological emergency. It is a form of extrapulmonary tuberculosis. And amongst the extrapulmonary tuberculosis, almost 3.5 to 6.3% of the cases of tuberculous meningitis are seen. I think we all know we are among the top, ours is a country which contributes most cases of tuberculosis in the world, and 2/3 cases of tuberculosis not get affected even if you have started these patients for anti-tuberculosis drugs. If it is MDR TB, it is a longer regime, and then 5 drugs are prescribed, either it is ubidapirin, leofloxacin, clofazimine, linezolid, or cyclosporin. Among some people, we prefer to give pyrazinamide instead of any of these drugs. Coming to second 18-year-old female came to us with history of fever, convulsion, and she had weakness on left side of the body. She was hemodynamically stable, but she was having neck stiffness, bruises, legs, and breast, and she had zero power on left side of the body. When we did the MRI, we found there was conglomeration of tuberculoma in right cardiovascular region. CSF showed high proteins, lymphocytic predominance. CSF VIMS expert again detected microbacterial tuberculosis and rifampicin. She was rifampicin sensitive. Again, this patient was given dexamethasone, steroid plus AKT as we discussed, and in addition to that, she was started on levetiracetam for her conversion. These are the MRI scan films of this patient. After the end of 1 year, this patient showed complete resolution of tuberculum. But what are the indications of surgery in tuberculoma? If tuberculoma is too big and is causing obstructive hydrocephalus, this tuberculoma is not responding to medical treatment and patient is showing signs of raised intracranial tension, then there is definite role of surgery in tuberculosis. Coming to case 3, this was a 36-year-old female came with headache, convulsion, and blood dysuria. Patient was drowsy. Patient had meningitis signs present. This patient, when MRI scan was done on admission, it was absolutely normal. But when X-ray chest was done, it showed some dizziness in the lower zone. So HRCT was done, which showed bilateral lower zone consolidation. CSF picture again showed high proteins, high lymphocytes, and CSF gene expert also detected microbacterium tuberculosis, but the gene was very low and it was indeterminate when the rifampicin resistance was tested. This patient was also started on steroids, antituberculous drug, anticonvulsant, levetiracetam. But what happened during the course of the treatment, patient was improved, but there was worsening of her sensorium after 7 days. She was not responding to oral commands and not responding to painful stimuli. Now, what makes that can come to your mind? So, what are the degrees of neurological worsening on antituberculous treatment? One thing is that patient has developed, whether the patient has developed complications like hydrocephalus, there is hyponatremia. Patient's MRI scan was repeated. It showed because severe obstruction to CSF flow, the reabsorption of CSF, and that of raised intracranial pressure. What could be those signs? Patient has decreased level of consciousness, papillary edema, vision loss because of severe papillary edema, 6-month palsy, bradycardia, hypertension. And what is the treatment of hydrocephalus? We have to optimize our cellular available like effusion and endoscopic. Third, pressure will increase. Coming to case 4, this is a case 18-year female who came with history of low-grade fever, headache, and altered sensorium. Again, this patient was conscious and had meningeal signs positive. Patient CSF showed high proteins, lymphocytic predominance, CSF gene expert was microbacteria could not be detected. Hence, rifampicin sensitivity also we couldn't assess. General condition improved. However, on patient showed infarct, it was very confirmed with angiography also. Now, this is a clear of tuberculosis vasculitis, it is called tuberculosis vasculitis. We have to give anti-tuberculosis steroid, and then ecospherin was also advised to this involved in it. And now, what is the pathophysiology of that is why there is a poor blood circulation in the brain. And the infarcts that are usually seen due to vasculitis are either in the basal ganglia, pons, or cerebellum. Now, since this patient developed tuberculosis infarct, we started work on ecospherin. But there are trials which show that whether we can give we can give aspirin in all patients of tuberculosis meningitis to prevent infarct. And then there are definite trials. Aspirin, as we know, is a good antiplatelet agent, and a small dose of aspirin, that is 150 mg of aspirin, would be beneficial in this group of patients. There is no need to give larger dose of aspirin. This is another trial which shows safety and efficacy of an aspirin as an adjunctive therapy in tuberculosis meningitis. There are 3 randomized controlled trials by 3 different authors, and it has showed that starting aspirin as a preventive measure is also found to decrease the incidence of stroke, but there was definitely no mortality benefit. Moving to case 5. This is a case of 46-year-old who was HIV positive since 20 years. He had stopped his treatment 2 years back, and he came with history of convulsions, 2 episodes, and altered sensorial since one day. This patient also had meningeal signs, and when MRI scan was done, it showed multiple ring-enhancing lesions. Now, what are the differentials of multiple ring-enhancing lesions? All postgraduates remember this question will be asked, and this MRI will be kept in your postgraduate exam. So, amongst the infection, it is tuberculosis, neurocystic sarcosis, toxoplasma, and cryptogoma. It could be due to abscess, defective demyelination, glioblastoma, and metastasis. So, these are the differential diagnosis of ring-enhancing lesions. In the immunocompetent patient, we see many times a patient has come to us with headache, meningeal sign, and then this is the differential that the physician has to keep in mind, that whether it's a neurocystic sarcosis and tuberculosis, because there is a very it is sometimes becomes very difficult for us to differentiate between NCC and tuberculosis. But there are definitely some important differentiating findings here. NCC will not have meningeal signs, whereas tuberculosis will have meningeal signs. Thus, the ring-enhancing lesion is less than 20 millimeters in NCC, whereas in tuberculosis it is more than 20 millimeters. Then NCC is classic. Most of the time, these lesions are present at the junction of grey and white matter. Why? These are most commonly seen in tuberculosis. The lesions are most commonly seen in posterior fossa. In case of NCC, there will be this kind of lesions will be also there in eyes, muscles, and subcutaneous tissue. There is usually no midline shift in NCC, whereas in tuberculosis there will be midline shift. If there is a doubt, we can do MR spectroscopy. MR spectroscopy will show amino acid peak in NCC, whereas in tuberculosis it will show a lipid peak. Now, coming from HIV positive patient and tuberculosis, these are two special situation, and we have to take some special precautions when we treat such patients. We know, and because in patients of HIV, tuberculosis is the most common opportunistic infection. But whenever a TB occurs in HIV positive patient, the disease progression may also may take a serious turn. So mycobacterium TB is the most common opportunistic infection. Now TB and HIV, we have to have a certain things in our mind. If any patient of tuberculosis is detected to have HIV positive during this admission, we have to wait at least for 2 weeks for starting antiretroviral drugs. And in case of tuberculous meningitis, at least for 4 weeks before we start antiretroviral drugs. There are a lot of drug interactions that occur in with antituberculous drugs and antiretroviral drugs. So the treating physician has to be very patient and watchful. So this is what I said. Whenever there is HIV TB co-infected patient, therapy should be started as possible as within 2 weeks of initiating TB treatment, regardless of CD4 count. And in case of tuberculous meningitis, it should be delayed for at least 4 weeks. Now this slide is very important because there is something called immune reconstitution syndrome. So patient who has been diagnosed with tuberculosis and you have started immediately in this patient, just see the first time patient initially responds. But when you start ART, this patient again deteriorates or starts showing worsening. This is called as immune reconstitution syndrome. The second scenario is patient diagnosed as tuberculous meningitis or extrapulmonary TB, and he is a response to antituberculous treatments, but whenever there is ART started, again his neurological symptoms or the symptoms which we see may worsen. And then there is a third scenario where patient may be have a occult tuberculosis infection, but which was not evident. But when you start the patient on antiretroviral drug, suddenly the immunity improves and this infection becomes tuberculosis infection becomes evident. This is called unmasking of the TB. And this is called, these are the 3 different scenarios we have to remember whenever we are treating patients of tuberculosis with HIV. Now, what are the treatment options for high risk? Whenever there is either ART has started, either in a pulmonary or extrapulmonary TB, and patient shows worsening, how to be managed? Obviously, since again it is a type of inflammation or immune reconstitution, there is a definite role of corticosteroids, and normally we give corticosteroids, but in severe cases we can give thalidomide and TNF alpha inhibitors. However, I myself I have never used thalidomide or TNF alpha inhibitors. This is the study which was done in Africa, which shows that if it is severe high risk, we can give thalidomide in a dose of 3 to 5 milligrams per kg. And similarly, for infliximab, there are studies with severe paroxysmal tuberculous meningitis. If they are requiring very high dose of steroids, we can give infliximab. Now coming to cases, so we just saw we 5 different scenarios. First was the classical case of tuberculous meningitis. Second was Leprosy, third was tuberculosis, then tuberculous vasculitis. Then we saw HIV and TB before infection. Coming to case 6, this was a 41-year-old man who came for sick fever, headache, generalized seizure. Patient had signs of meningitis. He also had cranial palsy. CT showed nasal exudates. Patient had high proteins, high lymphocytic count, and low glucose. Patient was started on antituberculous treatment and dexamethasone. In the hospital, is sensorium deteriorated. First thing that you have to rule out whether this patient has hyponatremia because it is easily treatable condition. So this patient had serum sodium which was 106 milligrams per liter. We thought that this patient has the syndrome of appropriate radiate secretion, that is SIDH, and patient that time was euvolumi. So he was started with 3% normal saline infusion in gallbladder. Meanwhile, his other investigations, like serum osmolarity was low, but for the low serum osmolarity, urine osmolarity was very high. So it was like favoring SIDH. If this patient continued to have polyuria, is their volume decreased, his blood pressure decreased to 90 by 60, and then we thought of this is not SIDH and this is cerebral salt wasting syndrome. If you look at the chart, it's a cerebral salt wasting syndrome and SIDH have many things in common, but one that in both the conditions there will be low plasma osmolarity, serum sodium obviously will be low. In both the conditions there will be high urine osmolarity, but urine output in SIDH will be low, while in cerebral salt wasting syndrome urine output will be high, there will be polyuria. Whereas, and also urinary sodium will be very high in cerebral salt wasting syndrome, whereas in SIDH it will not be very high. The treatment for cerebral salt wasting syndrome is different. You have to give hydration, normal saline, and impact the patient on to restore his serum sodium. Just we have to see whether, as I told you, what investigation, what SIDH happens. You have to do investigation, and this, that is the end of my talk. We have seen most common and the most complicated cases of tuberculosis meningitis, as a 20% mortality. There has to be a prompt diagnosis, appropriate treatment, and high degree of success.
Thank you so much, ma'am. I would recommend you to go to the now we go on stage to enlighten us on topic.
Good afternoon. I'm sure I'm between your lunch and this meeting. This extraordinary tuberculosis is becoming very sad. But this study what is asked. Extraordinary tuberculosis is important. Treatment is very important because, as we know, we are going towards TB-free India. So, under the guidance of Vedantaa Madam and Asita Madam, we have done this. So, what is extrapolatory tuberculosis? The diagnosed case of TB. From my numerous observations, I can conclude that these tubercular bacilli occur in all tuberculous disorders and that they are distinguishable from all other microorganisms. So, my dear friends, don't miss this tuberculosis. So, I'll give you a small example. This is a case scenario which has come in the past in my experience. A 34-year-old married male came with history of pain during micturition and pain in suprapubic. He visited multiple doctors and was treated for UTI, but in vain. So finally, he was got to be in hospital where pelvis sonography was done and it was proved that there was mild prostate gland enlargement. I think this topic is TB, so you can easily diagnose. This is a case of TB prostate. Very rare, but it was missed out by many doctors. Since you are the future doctors, you should always remember if everything is negative, always think TB as one of the important part because we are ending our country's training. The second point is how to collect the sample. This was very, I remember this because I had personally gone to talk to urologist, and the urologist said that let's go ahead with prosthetic massage for a period of 5 minutes. White color urine, which is nothing but prosthetic fluid. And we grew Mycobacterium tuberculosis from this fluid. What is the challenge? Number one is delayed diagnosis. TB, everyone says, though there is a khasi hai, meaning like a fever, loss of weight, loss of appetite. But for extrapulmonary tuberculosis, there are vague symptoms. You may not even be able to diagnose it. And second important thing which you want to focus is specimen collection. If, as I always taught in microbiology, appropriate specimen collection is equal to appropriate reporting, is equal to appropriate treatment. If you don't collect the specimen properly, you will never get a correct answer. So, as first of all, I should say WHO and Ministry of Family and Health Welfare has really introduced this index TB guidelines, which is specifically for extrapulmonary tuberculosis. I would request all of you to at least go through it, you will get a complete idea. By 2035, we are planning for world free of tuberculosis. Pulmonary tuberculosis, as Ma'am has also said, major part is there in India. But we are having a lot of aspects to combat it. But what is the challenge for extrapulmonary? We have a low level of awareness among clinicians. No clinicians at the sample. I give you some examples also. Difficulty in sample collection, lack of right tools for diagnosis, and finally this guidelines will be read to everything will be sorted out. So there are multiple kinds of tuberculosis. I won't go in detail because Ma'am has also covered it. Tuberculosis lymphadenitis, pleural tuberculosis, tuberculosis of upper airways, genitourinary, skeletal tuberculosis, tuberculosis of CNS, tuberculosis pericarditis, gastrointestinal tuberculosis, skin tuberculosis, and finally urinary tuberculosis. So these are all extrapulmonary. Always remember, EPTB is very common in HIV infected patients. So along with, we always teach in microbiology, all cases of HIV, pulmonary TB to be tested, and all cases of TB, HIV to be tested. That is as per our guidelines. So we need to follow on this, and in this, EPTB is more common than pulmonary tuberculosis. So as I said, the most important is specimen collection. So optimal specimen collection is CSF, pericardial fluid, cytoplasmic and cytic fluid. Most of the postgraduate students love to collect swabs. I don't know why they are so attracted to that swab. Even if there is a fluid, they will dip the swab in the fluid and send the swab for culture sensitivity. My request is start collecting the fluids, that is more important. And just to inform you, gene expert, swab cannot be accepted. So that's why try to collect these samples where there are maximum concentration of TB vaccine. Some optimal specimens are sometimes pleural fluid, but it should be a large quantity, and blood should not be collected at one time. It can be done only in case of separated TB and coinfection. Swabs, again, it is only in laryngeal swabs that we take. And urine, it is very important because when we say sputum, it is intermittently shed. Same way, the urine also is intermittently shed. So the specimen to be collected is early morning specimen 3 times. The complete urine, it will be 200 ml, 300 ml. All urine has to be centrifuged, and the whatever is available that has to be processed. For stool again, it's the same. Other respiratory specimens also can be collected. They are invasive, like bronchial lavage, etc. And in case of children, gastric lavage is also. So, this is a surprising thing. If you know that if a patient of EPTB is there, sputum is positive in 10 to 50% of cases. If you see this, abdominal TB 20 to 50%. So take home message is for every extrapulmonary TB suspected case, please do send for everything. This is a second example. A known seropositive patient was complaining of diarrhea since 3 days. The stool specimen was sent. Obviously, whenever HIV positive is there, the first diagnosis is anyone? It's written Cryptosporidium paranoia, isospora. Opportunistic parasitic infection. And when this sample came to us, I was that time posted in parasitology. I saw all this acid fast bacilli with modified ZNC. We immediately did ZNC and then we found that it was actually TB bacilli. I called the patient. Unfortunately, the patient son picked up the phone and said, the patient expired yesterday. So again, what is important over here is the delay in diagnosis. So please note, opportunistic parasitic infection is not the only one in HIV infected patient, but we should not forget the TB bacilli also. So what we did was the most basic thing is microscopy. I think second MBBS we all have gone through. Ramstein and Zelenstein is most importantly taught to you. And what is taught is you have to process these lessons. Why is it asked? I think no PG student will be doing Zelenstein, but it is for you to become competent, for you to understand that TB can be detected with a simple Zelenstein. Please send the Zelenstein. Recently, RNTCP is coming up with a fluorescent screening, which is highly sensitive and more rapidly detected, just for your purpose. So this is a very interesting case. A 45-year-old married woman with 2 live children came with chief complaint of pain in left breast. On examination, the lump was palpated on USG, presented with pus. The pus was as usual. Every PG student will agree you have to just send it for culture sensitivity. But there was no organism grown. So what is the commonest organism causing breast abscess? Second year students, third year students. This Staphylococcus aureus. But there was no growth of Staphylococcus aureus. So what we generally do is we do ZN staining of the first. We found that acid path bacillus. So there is an important thing is there should be a lot of communication between clinician and microbiologist. So I called up the clinician, the surgeon, that the breast abscess has shown acid path. He said, impossible. I already started the patient on sulfuroxide. He said, you are doubting, let's send for gene expert. And the gene expert turned out to be wrong. So what does that mean? That all deep-seated abscess, please do ZN staining and if possible to send for condition. Because we are missing tuberculosis in such cases. So what are the different choice of tests we have? As a consultant, the first thing we do is microscopy. Second thing is culture. See, these are the common ones. The additional thing we do in detail is about the CME lab. And finally the tubercular susceptibility test. But along with that, RNTCP has come up with expert ultra as well as whole gene sequencing also. So till the time you pass amplification test, very easy to do. What is to be done? The patient is giving sputum or any body fluids other than urine. It has to be just put in this cartridge. The CBNAT is cartridge based. In the cartridge based, it is put in this machine, and the machine will give you the result. Completely automatic, nothing is required. But then some consultant has a concept in the mind. I want this sample to go to that XYZ lab only in Mumbai because that is a famous lab for TB. They don't have golden spoon or silver spoon to put the sample. They also have the same plastic spoon and we are putting the same plastic. Important for you to understand this is all an automated system which is found out. Even that lab has the same gene export machine which our lab has, but they say no, that lab is better. You have to be very, very careful and understand that CBNAT or gene export is very important for So how it is done? Can you see here? There is a single amplification curve. That means it is negative. MTB not detected. The machine is telling, I am not doing anything. Although I am a big microbiologist, having 50 years of experience, but machine says not detected means it's not detected. Over here, if you see, it is MTB detected and we found this is resistance not detected. You can see this is not detected. And the third one is both detected. So what am I doing? I'm just taking the reading and giving it to you. Give that reading to you, you should at least send the sample. And that's the biggest hurdle we have. Now recently I think very soon RNTCP will come up with a guideline stating that gene export is mandated for even sputum negative samples. Currently they are saying sputum positive should send it, but even negative samples are expected to be sent. So the importance is the positive prevalence of rifampicin resistance as well as detection is very high. That is a very important take-home message. So this is a very important graph. If you see, based on your gene expert, negative answer is not visible. If it is negative, then even if you are clinically suspicious, you to check for others like AFB culture, chest X-ray, HRCK, etc. And if it is positive, so if it is TB detected but rifampicin sensitive, then start the first line of work as per RNTCP guidelines. But if it is resistant and you are not suspecting MDR, please do a second test. This is an important taking message. Second, gene export, if it is rifampicin resistant, then only consider as resistant. And if it is resistant, again you start for the second. Now see the beauty, this is a scientific basis data analysis which clearly showed. Dr. Geeta Natwaraj from KM, she has done this study. Microscopy is only 40 positive out of 728 and culture is 164 positive. So that means 164 TB patient on microscopy I can detect only 40. But if you see gene expert, almost 96% are detected by gene expert. That's why, my dear friends, the take home message is focus on sending all extrapulmonary and sputum samples for gene expert. So that should be the initial test for all. This is another scenario. A 5-year-old child was given intramuscular injection 7 days back. Now developed swelling at the site of injection. Aerobic culture was sent to rule out bacterial, no organism see. I could see acid fast bacillus. You can imagine an injection given for TB or something, and you get an abscess over there. The first thing is obvious negative stamp or something, sorry. But I saw acid fast bacillus. Again, the clinician says, that's impossible. How can you say that? Okay, let's do something. So suspicion was more towards non-tuberculous microbacteria. What I told them was just get a gene expert done. The gene expert will be negative. So if smear is positive and gene expert negative, that goes more in favor of non-tuberculous microbacteria, which is also said over here. Because gene expert detects only MTB complex and not MTB. So whenever you have this suspicion, you can do this. And for other confirmation, you can send AFP culture where you can do this. What is the importance of gene export? Again, same day result, highly sensitive, 132 here. Of course, if you do culture, even 10 bacteria are there, they will grow. But here, minimum bacterial requirement is 1 kilo. It is completely automated, those platforms, there is no risk of any documentation. That is again important. So it is performed better in smear positive, that's why correctly it is said to smear positive patient. Does not detect any mutation, and most importantly, isoniazide resistance is currently not detected. This. So this is one of my students at KM. He was diagnosed with pulmonary tuberculosis. After completion of treatment, he started getting pain and abdomen. When detected, when tested, it was found that patient he had abdominal coughs, for which he took treatment for 1 year. MDR-TB. As soon as he finished with MDR-TB for abdomen, he started getting backache problem, and when the backache problem was investigated, it turned out to be he had spinal coughs, which was again MDR-TB. So what is the important lesson over here is when you do gene expert, culture is better than gene expert, but the government has come up with something called a gene expert ultra, which is equivalent to the if only you would have diagnosed early both the diseases, you would have not been on cricket for 2.5 years. Let me tell you, my dear friends, it is not easy to pay for 6 months for 2.5 years. So, this ultra detects even lesser number, 16 CFU of TB bacteria that is important. So, wherever available and possible, especially if possible in bacillary conditions like pediatric TB. So conventional culture again it takes 6 to 8 weeks, but automated culture like for example rigid it takes 2 to 4 weeks. But still culture takes a lot of time. I can't wait for 1 month to start the treatment. What I do is I literally go for gene expert, check for the result, and accordingly start. That's how gene expert. In conventional, better than conventional, rigid is preferred because it is faster. It is 3 to 4 weeks. What is another advantage of this is it detects only viable bacteria. Because sometimes the expert rather may detect dead bacteria also. Here they detect only viable bacteria and it is standardized for first and second. So culture should never be a problem. important. So again, the team message, whenever a sample comes, smear, gene expert, if the patient is EPTV, gene expert ultra, finally AFB culture. All these three things should always be there in your list of investigation for each and every patient where you are suspecting tuberculosis. So this is a major question which is there. Whenever there is difficulty in collecting another sample, for example, if you are taking pleural effusion, you have collected once, need not collect twice, send it for both collection as well. So there are some false negatives because of improper collection or sometimes overeating during transport. And there are technical flaws from microbiology side which I won't go in detail, but it is mostly transfer of one patient sample to other sample. I remember Neelam always used to say when you are seeing smear Vedantaa staining, the oil part, it should not touch the tip of the oil, it should not touch every smear. You should drop the oil from above. Because when a single acid bacillus goes on your tip, it will become false positive for all this. We used to see almost 100 to 200 slides every day. Why am I telling you this? Because every small aspect is important. If you give a patient as false positive, the patient has to bear treatment for 6 months. And after 2 months, patient goes, oh, I'm sorry, galti se apne aap ko treatment chalu hai. That's pretty shocking for us as well as for the patient. We have to be very cautious. Second important aspect, I won't go much in detail, but just for you to understand, anti-tubercular drug susceptibility or resistant testing is very important. My dear friends, any patient who comes positive, I know when the patient comes to the lab, am I MDR-TB is the first question because there is something called a Google doctor. We check on the Google doctor everything and they come for all these findings. So there is a need because we don't want the spread to happen. We want to start the patient as early as possible. I'm happy when Madam told that over here the mortality rate is almost reduced by 40%. 115 different gram panchayats are free of TB in Palghar. Why is that so? Because we are doing a lot of efforts. So drug susceptibility can be either by phenotyping method or molecular method. We are talking about molecular method. This is still not approved. All over India, there are only 8 centers which have been given to try it out. And if they are okay, it is approved, then only they will buy. Because if it is resistance, that means it is resistant. But if it is reported not as resistant, that doesn't make sense. And that's the big question mark we have over here. Overall, in drug resistant, the gene export we are using now, that is coming up not only with gene export and ultra, but it is coming up with export XDR technique, which can detect more than 5% drug of the susceptibility. Another one is line probe assay, and second one is targeted sequencing. So all these factors are very important. If you see, this is the line probe assay. All over here, when as per the band, they decide whether it is resistant or isoclinic or both resistant. We won't go much in detail on this, but if you see the newer trend is over here, that is called as next generation sequencing. So till the time you go out and start your own practice, this will be the upcoming thing to be available by. So finally, last but not the least is antigen detection. So there is a new test which is the only test approved by WHO, which is called as LAM test, lipo-arabinomannan test. It is just like our HIV immunochromatography test. There are 2 bands that it is positive, there is 1 band that is negative. It is said that TB bacteria secretes this in the urine. So just taking the urine of the patient and checking over here confirms that patient has TB somewhere in the body. It could be lung also, it could be external body also. But it should not be done in all patients. It should be done only with patients who have one TB symptom, and if they have advanced HIV or they are seriously ill or the CV. It is a rapid test. Within 10 minutes, you will find out patient for TB happening. Accordingly, you can go ahead and proceed for the treatment pattern and further management. This is the last scenario for all the surgeons who are there. A 30-year-old male underwent a laparoscopy, cholecystectomy, 1 month post-surgery, swelling was noticed at one side of the port. Notice laparoscopy, there are 5 or 3 ports which are made. First, there was a proper swelling, and first was removed and sent for aerobic culture. As usual, clinician always sent for only ground station culture. It turned out to be negative. But luckily, because we are doing reduction also, we found acid for bacillus. Anyone can guess what is this? This is nothing but a fourth site infection. If the sterilization and disinfection of the instruments are not properly done, the acid fast bacilli which is present in the water will go in the wound site and it will cause infection. So extrapulmonary TB we have plenty of things, and this is the last passage which could be a hospital associated. So to summary, this is the whole chart which we should remember, and based on this you decide which test to send for which patient. Accordingly, get the report as early as well, and let us come forward to make our India EV free as early as possible. Thank you.
Thank you so much, sir. Requesting Dr. Vinod, sir, to please come up on stage. Present Dr. Kuyare with a moment. All right, everyone. We will be moving ahead with the lunch break. Requesting everyone to please come back after an hour to continue the second part of the event. Thank you.
असं एंड करू का आता हे लंच ब्रेक झालाय तर एंड करू ओके चालेल राहू ओके ओके मी Okay, let's get the applicant. Camera is this too.
टिफिन में क्या है?